Welcome you all. I'm Dr. T. Raj, working in Emmanuel Research College of Pharmacy as assistant professor in the Department of Pharmacy Practice. Today we'll see a chapter in pharmacology. The chapter is the cholinergic drugs. In today's session, we will see what is cholinergic drugs and how it works, and we'll see what is anticholinesterase and how it works, and we'll see what is anticholinesterase poisoning and what are all the causes and what is the treatment for anticholinesterase poisoning, and we'll see a case study based on cholinergic drugs. So in the last PowerPoint you will be able to understand the basic knowledge about cholinergic drugs. So the content overview contains the cholinergic agonist. We'll see only the alkaloids in cholinergic agonist, and we'll see anticholinesterase and anticholinesterase poisoning, and finally we'll see case study. And before starting the session, we will just go through some definition that will be more relevant to your coming topics. So what is IOP, or intraocular pressure? It's a fluid pressure inside the eye, mainly maintained by the balance between production of aqueous humor and drainage of aqueous humor, and the normal range is between 10 to 21 mmHg. What is glaucoma? It's a group of eye disorder characterized by progressive optic nerve damage, often associated with increased intraocular pressure. Leads to irreversible vision loss. Then what is xerostomia, also known as dry mouth? Is the subjective feeling of dry mouth due to reduced saliva production or altered saliva combustion. The causes of xerostomia includes drug-induced, such as anticholinergics, then antihistamines, antidepressants, antipsychotics, and diuretics. Mechanism blocks muscarinic receptors, which causes decreased saliva secretion. Then what does SLUT stands for? S for salivation, L for lacrimation, and U for urination, and D for defecation. It is due to mainly by excess acetylcholine action. And the causes are due to excess acetylcholine, commonly in you can see in organophosphate poisoning and overdose of cholinergic drugs such as pilocarpine and neostigmine. And the mechanism or inhibition of acetylcholinesterase, which causes increased acetylcholine and which causes overstimulation of muscarinic receptors. And what is the Dumble symptoms? And D is for diarrhea, and U is urination, M is meiosis, and B bronchospasm, and E emesis, L lethargy, and L lacrimation, and S salivation. And this will be the main slide that you have to be more remember on it, because when you study the site and location of muscarinic and nicotinic receptor, you will be able to identify the cholinergic action as well as. So I'll just say the location and function. The M1 and M2 and M3. And M1 is in autonomic ganglia, gastric glands, and enteric neurons. Then M2, SA node, AV node, atrium, ventricles, and cholinergic nerve endings, CNS, visceral smooth muscles contraction. And M3, visceral and bronchial smooth muscle contraction. Then iris, ciliary muscles, exocrine glands, etc. And the subtypes of nicotinic receptor, as well as I will explain just the location and function. The NM is NM in neuromuscular junction and NN in autonomic ganglia, adrenal medulla, and CNS. And what is myasthenia gravis? It's an autoimmune neuromuscular disorder characterized by weakness and rapid fatigue of skeletal muscles due to defects in neuromuscular transmission. And what is urinary retention? Urinary retention is the inability to completely empty the urinary bladder, leading to accumulation of urine. And we'll just start the cholinergic drugs. Um, the previous slides just we have explained the relevant topics which are coming under cholinergic drugs. So by learning the previous slide, you will just it will be easy to understand the coming chapter. So we'll start cholinergic drugs. So we'll start with cholinergic alkaloids. Cholinergic drugs just mimic the action of acetylcholines, and alkaloids is a naturally occurring compounds act on more specific on muscarinic receptors, and it has a weak nicotinic action, and it is classified as pilocarpine, muscarin, and aricoline. Pilocarpine is obtained from Pilocarpus plant, and it's a tertiary amine, so it can. So as we know that tertiary amine can cross triple B, pilocarpine can also crosses blood-brain barrier. And the mechanism is a direct muscarinic receptor agonist, mainly on M3 receptor activation. We have seen in the previous slide the site and location of M3. So it will it will act on M3 receptors in different sites, and it will produce the parasympathomimetic action. So as we know that cholinergic drugs produce parasympathetic action. It's just mimic the action of parasympathetic system. So the actions are increased salivation and increased sweating and causes meiosis and decreases intraocular pressure. So I'll just explain the pilocarpine mechanism of action in eye. It acts on M3 receptor in the eye, stimulates M3 muscarinic receptor on ciliary muscles and iris sphincter muscles, and the effect on ciliary muscles causes contraction of ciliary muscles, opens trabecular meshwork, and increases aqueous humor outflow and decreases IOP. And effect on iris sphincter causes meiosis. That we know that parasympathomimetic action is one of parasympathomimetic action can causes meiosis. So it effects on iris sphincter can cause meiosis. This helps in opening trabecular meshwork further and improves drainage of aqueous humor. So this is just an image. It will help you to easily understand. So uses it is used for glaucoma treatment. So you know what is glaucoma we have seen in the previous slide, and it is used in xerostomia, and that we call as dry mouth. So when we give pilocarpine, it can cause stimulate M3 receptor, and it can increases the salivary gland and causes and can improves the secretion. And the adverse effect of pilocarpine includes sweating, salivation, bronchospasm, and hypertension. And important to remember in this topic is for pilocarpine. Pilocarpine produces only muscarinic effect and has no nicotinic action. So as we said that it can act only on muscarinic receptor and it has no nicotinic action. And the second drug is muscarine. The source found in Amantia muscaria mushroom, and it's a quaternary amine, and it does not process triple B. And the actions on it has strong muscarinic effects, and can cause salivation, lacrimation, urination, and diarrhea. So you need to more remember about muscarine. It can cause only muscarinic effect, and it has no nicotinic effect, and only no muscle paralysis. Toxicity causes mushroom symptoms, and the symptoms are slut syndrome. Is is muscarine a drug? No, it's not a drug. Muscarine is a natural occurring toxin, not a therapeutic drug. What exactly is muscarine? It's a natural alkaloid found in certain poisonous mushroom, example, cybans, psilocybin. Acts as a direct muscarine receptor agonist. It mimics acetylcholine at muscarine receptor. Why is it not used as a drug? Because it causes severe cholinergic toxicity, produces sludge, dumbbell symptoms, and can lead to bronchospasm, bradycardia, and excess secretion. So it is dangerous and it is not used therapeutically, uh, and it's not used for therapeutic effect. And the last one is haricolin. Its source is found in areca nut, and it's a tertiary amine, so it can causes the blood-brain barrier. In action, it has mild muscarinic and nicotinic action, and mild CNS stimulation. So, does aricoline causes nicotinic effect? Primarily, no. Clinically, then mainly produces muscarinic effect and not significant nicotinic effect. It has a very weak nicotinic activity, minor, and it is not clinically important. So, we can finalize that cholinergic alkaloids have only muscarinic effect, and it uses it has no major clinical use. Is aricoline a drug? Short answer, no. It's not used as a therapeutic drug in modern clinical practice. Then the second chapter is anticholinesterase. It's an agent which inhibit cholinesterase and protect acetylcholine from hydrolysis, produces cholinergic effect. And quaternary ammonium anticholinesterase like neostigmine have additional direct action on nicotinic choline receptors. And the classification of anticholinesterase, reversible and irreversible. In reversible, we have divided into two. One is carbamates and non-carbamates, and in the reversible, yeah, carbamates and organophosphates. And mechanism action of anticholinesterase. So normally without a drug, acetylcholine is released at the synapse and acts on receptors. Then it's quickly broken down by acetylcholinesterase. So signal stops and there is no acetylcholine activity. This is the normal mechanism for our major functions. And with what happens with anticholinesterase drugs? They inhibit acetylcholinesterase. So while inhibiting acetylcholine is not hydrolyzed, so acetylcholine bug is increased. So acetylcholine is not broken down, so it accumulates in the synaptic cleft, leads to increased and prolonged stimulation of muscarinic receptors and nicotinic receptor action. And the pharmacological actions, all effects are due to increased acetylcholine. So we'll start with the muscarinic effect, which causes decreased heart rate, bradycardia, and increased gland secretion, saliva, and sweat, and can cause bronchoconstriction and and increased geomotility, and can cause meiosis. And nicotinic effect, ganglia and initial stimulation, then blockade at high doses, and skeletal muscles, low dose twitching and increased contraction, and high dose which can cause paralysis. And CNS effect, only lipid soluble drugs like physostigmines. Mild dose alertness improves cognition, and high dose confusion. Then it can causes coma, coma as well as. And pharmacokinetics, I have just described in a Simple words. A physostigmate, a lipid soluble, and it can crosses triple B and works in CNS. A neostigmate, water soluble, does not crosses triple B, acts peripherally. Organophosphate absorbed through skin and lungs. And use of anticholinergic drugs used in glaucoma, um, myasthenia gravis, and post-operative ileus and urinary retention, stimulates smooth muscles, and it can be used in reversal of muscle relaxants after surgery, and it can be used in Alzheimer's disease to improve memory, and is used in belladonna poisoning. And what is anticholinergic poisoning? Anticholinergic poisoning is a condition caused by excess inhibition of the enzyme acetylcholinesterase, leading to accumulation of acetylcholine at nerve synapse. And what happens when acetylcholine is blocked? Acetylcholine is not broken down; it builds up at muscarinic, nicotinic, and CNS receptors. This causes continuous overstimulation of cholinergic system. So, in simple words, when anticholinesterase poisoning occurs, there is no breaking down of acetylcholine. So it is not hydrolyzed. So acetylcholine is it as acetylcholine, and there is no there's not happening of hydrolysis of acetylcholine. So what happens? So acetylcholine works too much and causes too much parasympathomimetic action. That's why we have we are calling cholinergic drugs as parasympathomimetic or cholinomimetic drugs, and causes organophosphate insecticide poisoning, example parathion and malathion, and carbamate insecticide, example carbaryl, and overdose of drugs like neostigmine and isostigmine. And symptoms, and the muscarinic symptoms like salivation, lacrimation, urination, increased urination, and diarrhea, and bronchospasm, and bradycardia, emesis, meiosis, and sweating and salivation. And nicotinic action, muscle fascination, um, and weakness causes paralysis, respiratory muscle failure, then CNS, anxiety, confusion, and even coma can occur. So mainly in anticholinesterase poisoning, the cause of death is due to respiratory failure. And the treatment of further exposure to the poison, fresh treatment of further exposure to the poison, then fresh air, wash the skin and mucous membrane with soap and water, gastric lavage according to need, and maintain patient airway and positive pressure, maintain pattern airway, positive pressure, respiration if it's failing. And supportive measure, maintain BP, hydration, control of conversion with use of diazepam. And specific antidotes, mm, anticholinergic drugs such as atropine and cholinesterase reactivator pralidoxim. So we'll start coming to the last topic, the case study. In this, by going on through the case study, you will able to understand the cholinergic's basic concept. So, case a 28-year-old farmer is brought to the emergency room after spraying pesticides in the field, and so he's sweating and heavily salivation, and he has constricted pupils, pinpoint pupils, and vomiting and uh, passing stools, and breathing is difficulty with wheezing. Muscle twitching is present. His relative says he collapsed within 30 minutes of exposure. So by seeing the symptoms, it is related to the cholinergic drugs poisoning, such as acetylcholinesterase poisoning. The symptoms are we have seen before. So, what is the most likely diagnosis, and what type of drug poisoning is this? And explain the mechanism behind these symptoms. Why is respiration affected? What is the immediate treatment? Diagnosis: it's organo-OPC poisoning, and the type of poisoning is irreversible and acetylcholinesterase inhibition causes cholinergic crisis. And mechanism: organophosphate inhibit acetylcholinesterase enzyme. So acetylcholine accumulates at muscarinic receptors and cause and stimulation of M3 muscarinic receptors, and causes stimulation of nicotinic receptors and cause excess activation of acetylcholine and action on CNS, confusion and seizure. Why breathing is affected? It is affected because of bronchoconstriction and excess secretion, and respiratory muscle paralysis due to nicotinic effect leads to respiratory failure. Treatment: um, atropine blocks muscarinic effect. This is an anticholinergic drugs which produces sympathetic action, the opposite of parasympathetic. And pralidoxim reactivates acetylcholinesterase. If this works only if it is given the treatment started earlier, and oxygen and airway support. So, summary: these drugs increase acetylcholine, but too much can cause dangerous poisoning, affecting breathing and muscles. So, uh, coming to the end, basically, cholinergic drugs are due to excess activation of acetylcholine. It can be due to anticholinesterase, and it can be due to cholinesterase, it can be due to choline alkaloids. The normal basic concept is increased activation of acetylcholine. So, hope you all understand the basic concept of cholinergic drugs. We have seen cholinergic alkaloids, acetylcholinesterase, and acetylcholinesterase poisoning, and we have seen the case study. So, so I have so this will be able you to understand the basic concept of cholinergic drugs. So, thank you all. This topic is this will be very useful for the second year students for your better understanding. Thank you.